So I'm very happy to present to you today the results of a prospective phase 2 study, investigator-initiated, that evaluated the clinical outcomes, immunophenotypic, and biomarker analysis of intercalated Avelumab plus platinum-based chemotherapy in patients with extensive-stage small cell lung cancer, the so-called PAVE study, that was recently presented at the European Lung Cancer Congress in Prague, Czech Republic. So we started from the notion that extensive stage small cell lung cancer is an incurable disease with poor prognosis, and that available treatments, first-line treatments with platinum and etoposide chemotherapy plus an immune checkpoint inhibitor, either atezolizumab or durvalumab, are currently conferring modest improvement in median overall survival as compared to chemotherapy alone of approximately 2 months. And this survival benefit is restricted only to a limited proportion of patients. So, having said that, we hypothesized that if we administer the anti-PD-L1 monoclonal antibody Avelumab in an intercalated fashion, meaning after 2 induction chemotherapy cycles and in specific time intervals in between the chemotherapy cycles thereafter, we could further enhance immune responses against tumor cells by taking advantage of the big release of neoantigens into circulation while minimizing the immunosuppressive effects of chemotherapy on T cells. So, starting from this, we designed the PAVE study, which was a prospective, single-arm, multi-center phase 2 study that was preceded by a safety run-in period that involved 6 patients. And subsequently, in the phase 2 part of the study, patients with untreated extensive stage small cell lung cancer and a performance status of 0 or 1 received standard chemotherapy with cisplatin 80 milligram per square meter or carboplatin AUC5 on day 1, plus etoposide 100 milligram per square meter on days 1 to 3, every 3 weeks for 4 up to 6 cycles. And Avelumab in the dose of 10 milligram per kilogram of body weight was administered every 2 weeks, starting from cycle 3 onwards until chemotherapy completion and as maintenance thereafter. Importantly, the primary endpoint of the study was 1-year progression-free survival rate, while objective response rate, median PFS, safety, quality of life assessment, and overall survival were secondary endpoints. And I would like to underline the fact that we had a translational part in the study with genotyping of fresh frozen paraffin-embedded tumors via targeted NGS, and we also assessed tumor-infiltrated lymphocyte density, and we analyzed CD8 positive T cells and PD-L1 expression using immunohistochemical analysis. Of note, patients with stable brain metastasis were allowed to enter in the study, and according to the statistical hypothesis of the study, for an increase in the 1-year progression-free survival rate from 10 to 25% that was considered to be clinically relevant, we had to recruit 55 patients in the study. So, first of all, I would like to talk a little bit about the patient clinical characteristics. We had a typical small cell lung cancer patient population with extensive stage disease. Approximately 1/3 were females. Approximately 1 out of 4 had received prophylactic cranial irradiation. More than half of patients had liver metastases. 1/3 of patients had bone metastases, and 11% of patients had brain metastases at the time of diagnosis. So, moving to the outcomes, after a median follow-up of 10.3 months, we had 55 evaluable patients for response according to the statistical plan, and we had 52 events of progression or death, and 50 patients had died. The primary endpoint, the 1-year progression-free survival rate among these 55 evaluable patients, was 12.7%, corresponding to a median PFS of 6 months The 1-year survival rate was 38.2%, corresponding to a median overall survival of 10.3 months. We had 3 long-term survivors achieving survival of more than 3.5 years. All of these patients were in complete remission. Objective response rate was 69.1%, corresponding to a median duration of response of 5.6 months. We had 3 grade 5 events, 1 event of myocardial infarction, 1 stroke, 1 febrile neutropenia, none of which was deemed related to Avelumab administration. We had 1 patient discontinuing due to a grade 3 allergic reaction to Avelumab. And overall, we had grade 3 to 4 clinically relevant adverse events occurring in slightly more than half of patients, 56% of patients. And in the intention to treat population, the overall quality of life, global health status, and disease-related symptoms were significantly improved. Moving to the translational part of the study, we had all but 1 tumors carrying genetic alterations, typically TP53, 90% of these tumors, retinoblastoma 1 knockout mutations in 58% of patients. And we also had genetic alterations in the Notch pathway in 31.6% and MYC amplification in 24% of patients. Those were the most frequently altered genes. We had 1 case of a hypermutated tumor corresponding to 1 long-term responder, achieving median overall survival of 3.75 years, 3.5 years. And importantly, we saw that immunohistochemical expression of tumor-infiltrating lymphocytes, so the TIL density and the presence of CD8 positive tumor-infiltrating lymphocytes did not have any predictive or prognostic value for clinical outcomes. In multivariate logistic regression analysis, the presence of liver metastasis at diagnosis, the identification of RB1 or co-mutations in RB1 and TP53, no prophylactic cranial irradiation, and older age, more than 65 years, were independent negative prognosticators for both progression-free survival and overall survival in the ITT population. Thank you for this question. So we believe that these data are clinically relevant. First of all, we showed that an intercalating strategy of immune checkpoint inhibitor administration in the first-line setting of extensive-stage small cell lung cancer is clinically feasible and is well tolerated. We saw that the trial was not positive in terms of the primary endpoint, so we have to say that intercalated Avelumab administration with platinum etoposide did not meet the primary endpoint of 1-year progression-free survival. Of course, we have to acknowledge basic limitations of the study that include the small sample size and the lack of predictive biomarkers for outcomes. Of note, the immunophenotypic profile in terms of CD8 positive tumor-infiltrating lymphocyte density did not seem to harbor prognostic or predictive value. However, we have some clinical prognosticators, including the presence of the TP53 RB1 co-mutation, which is a negative prognosticator for both PFS and OS in multivariate logistic regression analysis, and this should be taken into account into clinical practice. And our overall conclusion is that despite the negative outcome for the primary endpoint, nevertheless, we saw that this intercalating ICI strategy confers comparable efficacy to published frontline chemo-immunotherapy regimens that have been published so far, including clinically relevant PFS, duration of response, and improved quality of life. And therefore, we consider that this combination, this strategy of intercalating immunotherapy merits further investigation. So this is a very intriguing question. So we are now in preliminary stages of discussion with several sponsors for expanding this strategy of intercalating immunotherapy in a larger patient population, perhaps in a phase 3 study comparing to standard chemo-immunotherapy approach. And we also exploit the potential of identifying biomarkers that could identify the patients that are more likely to benefit from such an intercalating immunotherapy strategy. So I hope that we will hear more about this strategy in the near future. Acknowledge all the patients and their families, all the investigators, the co-investigators of the PAVE study, which was an academic initiative, an academic collaboration. My co-primary investigator, Dr. Elena Linardou from Metropolitan Hospital in Athens, Greece, and of course, you, ecancer, for the kind invitation, and all of you for listening to this presentation. Thank you very much.